good morning, everyone. I think the mic is a formality, but let's start with it. And thank you for being here. And we learn this time after time that when you have an early morning course, although you don't have people outside of your group who might be listening to you, but I think for me, we learn a lot because we discuss amongst ourselves and we get time to really understand what we are doing. So we have, I thank Dr. Rohan and Dr. Tushya for being here early this morning, and Dr. Gaurav Luthra will be joining us. Dr. Vandana Nath, our own team member from REH, so no special thanks, but thank you for always being there. Let's start with this topic of nucleus rotation, tackling the slag in successful phaco. I'm talking on behalf, originally this was to be presented by Dr. Prakash Chaudhary from Bangladesh, but because of visa issues, unfortunately, he couldn't make it. So, yes, we do receive occasional research grant from Alcon Laboratories. Let's start with this case of a 66-year-old lady who was scheduled for a routine cataract surgery. And as you can see here, this clip I've put just to show that this is the end of fragment removal and everything looks absolutely fine. Now just notice here when the IA is started, this is when the surgeon, while performing aspiration, noticed a zonular dialysis. And very smartly, the good thing the surgeon did was to start off by refluxing. Reflux on your pedal, that is something you need to know if you catch a posterior capsule or some vitreous or whatever you didn't want to catch. Now going back, the point is, why did this happen? Everything looked quite okay. So the one point that I have learned is to record all your videos, because if you want to review or if you want to go back to them, you should have something to go back to. So this is a phase where a sculpting was done. Hydro had been done prior to this, but the nucleus rotation is being performed. And here you can see what is happening. So it was an, what do you say, a wrong or a bad technique of nucleus rotation, a forceful rotation, push and too much of pull towards the center, although the nucleus was not free. So this was the reason why this happened. So the thing that we learned from this case was that always when you are rotating with a spatula, it is important to understand the physics of nucleus rotation. First prerequisite is to have a good hydrodissection. If you cannot do hydrodissection, let's say in a posterior polar cataract or a pre-existing rupture of any kind, please do not obviously perform hydrodissection. But after a cortical cleaving hydrodissection, it is important to go down and then perform movements with your wrist rather than pushing down. The thing that was happening in the previous case was pushing down too much, which was causing a stress on the zonular complex and caused that dialysis eventually. So as you can see in this animation, this hand figure here, try to make it a swiping motion. Now not every time it will happen that this rotation works perfectly or completely in the first time. This case I have put up to show that a sculpt is being made, and this is what we call an ideal rotation. So where you don't press, you just be on the surface and you do a swiping rotation movement with your wrists. Now here a chop has been created. You can see here that the surgeon is struggling to rotate. So at this point, the smarter thing would be to stop and perform a multi-quadrant, small aliquots of hydrodissection in more than one quadrant. And we like to use this special angled cannula. It's not very fancy, made by one of our own Indian companies. So do it in 2 or 3 quadrants, and then as you can see here, the nucleus will rotate freely. But I think rotation is such an underrated step, because until the nucleus rotates, it is imperative that you don't start any further maneuvers. You may need to stop at any stage where you feel the nucleus is not moving and rehydro until that rotation is free. Good morning, ma'am. Thank you for being here with us. Thank you. So again, like I said, if it does not rotate, then please rehydro at any point. So going back to the original case that I showed you, if you remember, there was an sub-incisional about 2 to 3 clock hours of zonular dialysis. So here the point is putting a CTR, not a very technical thing. You can do it manually or through an injector. But what I wanted to highlight is that here we are using a 10-0 nylon suture, which we have threaded into one eyelet. Why? Because not every time it goes into the desired plane. Sometimes you end up in the sulcus, or sometimes you realize that there was a rupture in the fornix also, posterior capsule rupture, and then it's very difficult to retrieve the CTR. So we like to keep the CTR with the suture in place, and we then cut off the suture once everything is done and then just pull it out. So this is, I think, that case to show the importance of the physics of rotation and what to do if it doesn't rotate. Now this case here, you see that hydrodissection, a good wave has passed. Now once you see that a good wave has passed, what now I like to do, and I think most surgeons at our both centers like to do, we don't check by doing a rotation. We straight ahead go and create a nuclear division, and then we use the chopper in the fornix or the wall of that chop that we have created to rotate the nucleus. So I think if you have a good rotation, you really don't need to, if you have a good hydro, you really don't need to confirm. So you can always crack, and I like to do that also, because once you create a crack or a chop, there is a space through which the fluid from the phaco tip will also flow, and that also aids or augments the hydrodissection. Now again, it's very important when you are using even a chopper for rotation, it's not a great idea to embed the chopper on the surface and rotate. Rather keep it vertical and in parallel to that to the vertical wall of the crack, and then again same wrist rotation like a fulcrum. And the last part of this talk, I want to talk about corticocapsular adhesions. The most common reason for that snag that happened, why it did not rotate despite doing a good hydrodissection, is the presence of these whitish materials called corticocapsular adhesions. Now biochemically they are basically strong adhesions between the capsule and the underlying cortex. And how do you recognize this from a cortical cataract or distinguish it, is the fact that you will not see any space on slit lamp evaluation between the anterior capsule and this opacity. So this is what we call a CCA or a corticocapsular adhesion, whereas here if you see, this is a diagrammatic representation, and this is what clinically it would look on the slit lamp. You will see some space between that cortical opacity, so this is not a true capsular adhesion. So this is important to see in pre-op with a full dilated pupil, so that particularly when you are in a training center or you have multiple surgeons, the person doing the pre-op should mention that this patient has CCA, so that you do a multi-quadrant hydrodissection preemptively. Because as we can easily understand, these adhesions will actually block or stop the passage of a successful wave. And this is, it's a very old picture, but it's a classic one which actually shows what these adhesions look like. And like we discussed in the previous clinical examples, doing a multi-quadrant cortical cleaving hydrodissection not only helps you, but it reduces the time used and the fluid used during the surgery, because it frees up those fragments. And this was documented with the team of Dr. David Apple lab several years ago. So I think in end, rotation, like with any other step, incision, rexes, each step is very crucial, and look for corticocapsular adhesions. Avoid any stressful rotation. Start a crack and try to rotate. If that doesn't work, rehydro, and you can rehydro 1 to 3 times without creating too much pressure, small aliquots. So that's it, I think, on my part from the rotation snag. Now it's my real pleasure to invite next up Dr. Rohan Mehra, and he's like another star sitting. These are all the rising stars of our Indian ophthalmology, and thank you, Rohan, for being here this early morning. He'll be talking to us about a runaway rexis.
And that was a great presentation. Just wanted to ask you, ma'am, at times you have an underlying zonulopathy. So in those cases also you have a difficulty in rotation. So any tips on that?
So I think that's a great question, that when you know or you have found out a zonular problem, one is to use angled cannula and do 2 or 3 small boluses, small aliquots of hydrodissection in that area. And what I also like to do is to do a viscodissection. So we use a dispersive viscoelastic, chondroitin sulfate, and once you do a hydrodissection, you have some space, and I would go through a side port or the main port depending on where that zonular loss is, and I like to perform a viscodissection because one, it frees up, second, when you are performing your maneuvers, it gives you a little cushion. So I think that's also one good idea. Thank you. Any other tips from the experts, Chitra ma'am sitting here, what you would do differently?
Ma'am, what I at ti-
Yes.
Yeah.
what I
Absolutely.
like, I also do one thing differently. Like in cases of generalized zonulopathy, I do a bimanual rotation. So at the same time, you place your phaco tip and the chopper, as you said, it should be placed right in the center, using the angle of the tip, and then you just rotate it. So it simultaneously. So that also like
Yeah,
at
I think
times,
that's also a very good tip because it reduces any focal zonular
yeah.
stress. So great point, Tush. Thank you.
The first case that you showed, ma'am, you went back and you saw that but the rotation was incorrect. But do you think that incorrect hydrodissection also, like hydrodissection not going through on that part, rest of the maybe out of the 360, maybe 330 degrees got hydrodissected, but that part of it did not get hydrodissected, and then there was a forceful movement, and that caused the bag to come
True,
in.
true. So I, like you very rightly pointed out, most of the times there are two issues. One, like we discussed, the corticocapsular adhesions, which will prevent a successful hydrodissection 360 degree, like you said. The other thing, sometimes you, and unintentionally you end up with hydrodelineation, where it's not really between the cortex and the capsule, a little sliver, it goes subcortical, I would say. So that hydrodelineation also is a factor which doesn't sometimes allow. So both a prerequisite of a bad rotation is either adhesions or inadequate hydrodissection, I think.
So, ma'am, are you doing regularly multiple quadrant hydrodissection in overly soft cataracts? Because you know you have strong corticocapsular adhesions in that.
So I do at least two quadrants before I start, and then if it doesn't rotate after my first nucleotomy or division,
Okay,
then I would go ahead and do two more quadrants subincisionally.
thank you.
All yours.
Thank you so much. A very good morning. Early in the morning, thank you so much, Dr. Vaishali ma'am, for including me in this IC. So I am going to be talking on reining in the runaway rexes. It is very, very important to secure this perimeter. Why? Because we have to build our cataract surgery step by step. Each step is very important. And we know that starting well is extremely, extremely important in a cataract surgery. Well begun is half done. That is what Aristotle said. So I'm going to be showing you a few cases of mine wherein there are a few cases where I was able to rein it in, and there were a few cases where I wasn't, and then how I basically tackled them. So I'll start off with this first case. So here you see that it is a very intumescent cataract, and we are debulking it. Once we have debulked it, we know that the lenticular pressure is not that high, and we'll be able to basically get a beautiful rexis. What is important is to hold the rexis from the edge, keep holding it from the edge, remove your forceps, and then again hold it from the edge, and then you'll be able to get a proper rexis in these cases. So here's another case. Again, this also is not exactly an intumescent cataract, but a very hard brown cataract underneath. So what is important in this case is you see that once the rexis is started, now there are two sort of scissor mouths that are there like a vampire. So there was one there and there was the other one. So I took the one that was on the outside. I started rotating and making my rexis. But you see, once I'm finishing my rexis at the end, I make sure that that edge gets included into my rexis. Because if I don't include that edge that was created initially while creating the flap of that rexis, then that can be pulled by the phaco probe because it's going to be pronging outside. So you'll see that I will increase my rexis size right at the end so that that edge gets included into my entire capsular rexis. So now I have a complete smooth rexis margin that is there. So in a few cases, even when they're not intumescent, you're going ahead doing a normal capsular rexis. What you need to do very importantly is sometimes pause. You see carefully what is happening. I'm now recognizing that this rexis is going out. Something is not right. This rexis is going out. So I will basically pause, I will slow down, and I will make sure that I do a slow motion rexis. Now, despite my efforts of pulling it in, it was still going out. So I came out with my instrument, re-injected viscoelastic, and then made sure that the movement of my cystotome is such that the force will not let the rexes run out. So you see here, now once I have reached this 3/4 level of this rexis, again look at the movement of my cystotome. That movement has to be completely inwards because I have to anticipate that on the other side the rexis was going out, so it is probably going to go out on this side as well. So you don't mind making a smaller rexis on the other side rather than getting greedy and trying to make a bigger rexis. So this is another case here. Again, I start my rexis out. I'm going in with the movement, the centrifugal movement that I require. And you see, once I have reached half of the rexis, again, I will pause. It is not necessary that I completely finish the rexis in one go. I will pause. I will remove my instrument. I will re-inject visco. I will form my AC. And then from here onwards, I use a microrexis forceps, and then a simple straight movement of the microrexis inside will cause this rexis to curve inwards rather than going outwards. So you need to basically notice what the movement of the microrexis forceps was. It was straight inwards rather than curving along the rexis margin. So in a few cases, you have to live on the edge. So in this case here again, you start the rexis, on top it is going in fine, but here you'll see that it is absolutely right on the edge of my pupil. So the point to be remembered here is, on a lot of occasions, especially when we are starting out, we tend to feel that the margin of the pupil is how big the lens is, the anterior capsule is. But sometimes the size of the pupil can be very misleading. A smaller pupil will make you make a smaller rexis, although there is a lot of room that is there outside that pupillary margin also for you to make that rexis. So you see in this case here, again, you're starting out the rexis. As ma'am mentioned, in this case, you can see a lot of adhesions that are there right at the bottom over there. So once again, you start out the rexis, and then once you finished the 3/4 of it, you notice that the rexis has gone out. But again, as the point I mentioned on the previous case, this pupil margin that is there right on top, there is a lot of space that is there beyond that pupil margin also for me to go and make that rexis even beyond that. So we don't have to get misleaded by the size of our pupil. Even though the rexis had gone out beyond the margin, there was still enough space over there for me to rein it back in. This is a case of a traumatic cataract where you can see the markings have been done. So we're planning a toric in this case. Again, you see that the rexis is coming right on the edge. The tendency of this rexis is to go out each and every time that I'm trying to make that rexis. So now right at the end, you'll see there is another way to deal with it. I'm trying again with my rexis forceps. I'm trying to rein it in. Now I'm seeing that no, this is not going to be pulled in. It is going out. So what I'm going to do is, I'm going to take a scissor and I will basically cut this rexis right at the end, because I know most of my rexis is already complete in this case. So I'm going to take a scissor and I'm going to cut that rexis margin off from there so that I get a nice circular round rexis. So in this case again, now I was lucky enough because it was a young patient that I could just go in with my irrigation aspiration cannula, and this central plaque sort of a thing that is there, I'm able to push it up. Once it is separated from the side of the bag, then I go in with my epinuclear settings and then I remove this, the plaque that is there. Now this also has a posterior plaque that is there. So once I'm done with my irrigation aspiration, I try to take that same cystotome needle that I had taken in the beginning and try and sort of remove this plaque by tugging away on it. Once I realize that no, it is completely adhered to the PC, then I don't touch it. I leave it like that. Now I'm trying to do this case is a perfect example of a Murphy's law. Whatever wrong has to happen will keep happening in each case. Now this lens has opened upside down and it's a toric lens. So I had to flip it over, and then it is a 4-plate haptic lens. So then I had to rotate it so that it comes onto that the angles that I have marked over there, and then I'm able to finish this case. Now this case will have to be yagged later because there was no point of taking that central plaque that is there posteriorly out. So not every single time things go hunky-dory, things go well. in a few cases, what happens is we get extremely greedy. So you see in this case, I start off with my rexes. I get a very, very nice round, but yes, very, very small rexes. So once I get a very small rexes, then I get very greedy in this case. I feel that, let me just enlarge this rexes. I'll make a nick and I'll be able to enlarge it. Reason was that when I tried to rotate it, it did not rotate. When I tried to do a hydrodissection and then tried to rotate it, it still did not rotate. So I was very skeptical that, with this small rexes and this rotation not happening, will I be able to finish off this case? So you see what happens here. I go in, I try and make a nick. I get greedy. I think that I'll be able to make a bigger rexes. And the moment I make a cut, it's gone all right the way through. The moment I've made a cut. Now what I've done is I've tried to rotate it onto the side so that I can get it, but no, it is completely on the side of that cut only. The reason why this was incorrect was because the cut that I had made was completely straight tangential, whereas the cut that I should have made should have been at an angle, and then I would have been able to rein this rexis in. Luckily, I was able to chop this nucleus out. Once the chopping was done piece by piece, I was able to remove the entire nucleus out, because I had got enough space on one side of the rexis that had happened. Putting in the viscoelastic and then doing my IA again, had to be very, very careful because the rexis had got extended on one side of it. I was trying to make it circular on the other, but couldn't. Luckily, I was able to implant the lens in the bag in this case. You feel happy when you finish cases well, so give yourself the gift of done. Thank you.
Thank you, Rohan. Those were some really nice cases and very well managed. I think I would just, I had 2 or 3 things I wanted to say, that like you showed that if you have a small pupil, with some experience you do eventually realize that, yeah, this is behind the pupil, but it hasn't gone to the periphery. But still, I have done this many times and suffered, so I would still recommend, if you have a doubt, use either an iris hook and hook up the pupil. If not, at least use some of those Y or V hooks and just make sure that what you are doing movement is within pre-equatorial. You are not going to the periphery. Second thing, if you have a peripheral extension, again, whenever you come out, when you exchange instruments, I would inject viscoelastic, ideally dispersive, but because when you're doing a rexis, you want a heavy cohesive, particularly in white cataracts, sodium hyaluronate. And if you have an extension, you would want to use some OVD before you bring out or exchange your instruments. And then, like Dr. Om Prakash sir, Dr. Rohit sir has explained, while doing the phaco, obviously you drop your parameters, but you look at whether that margin is flapping or not, the flap sign.
Motility. Yeah.
Any other comments from the...
One thing wanted to add about Little's maneuver, that even you can use that like 100 degree. You can pull it 100 degree to the extension of the tear, to the line of the tear, and it comes back. And as ma'am rightly mentioned, we can use hooks whenever it is not visible and it has gone beyond the equator. Yeah, and yeah, that's a very good point. Ma'am is saying that we should always fold it, and if we are using viscoelastic, it should not be in the line of the tear. It should be on the opposite side of the flap, so that can also cause an extension.
In a white mature cataract, Dr. Vasauda has always taught us, you start with a small rexis, what you rightly did, and try and aspirate as much of the cortex as possible so the lens is not so intumescent. And as you very rightly said, the cut should be at the angle in the direction in which you're going to increase the rexis. So what we usually do is we try to remove as much of the cataract through the small rexis, and we also implant the lens, and after the lens implantation, then we increase the rexis size.
Yeah. In hindsight, I thought that in that last case where the iatrogenic runoff had happened, after that small rexis mode made, I could have done a bit of IA. That IA would have removed all the loose cortical matter that is there and would have decreased the lenticular pressure that is there.
Yeah. So thank you, Rohan. We now have, yeah, I'll just put it on for you. I think the mic, I can speak loud enough. Dr. Vandana Nath, our cataract, cornea and low vision specialist from Raghudeep Eye Hospital, Ahmedabad. She will be talking to us about a very common problem that we all see and mostly ignore, but sometimes you can't just ignore it.
Good morning. Thank you, Dr. Vaishali, for including me in this course. The case of the ubiquitous incisional Descemet's detachment. All of us as cataract surgeons wish to have an absolutely clear, crystal clear cornea on day one. But philosophically speaking, life throws us some surprises. So let us discuss this case of a 67-year-old female with a grade 3 plus cataract. And the left eye was already done 3 weeks ago with a Vivity toric. And now we are operating the second eye, which is the right eye. So naturally, with the second eye, also the patient has expectations that it will be as good as the first eye. So this is what the surgery has gone on uneventfully, and we are implanting the lens, and everything on table is absolutely the way it should be, the textbook kind. And we're removing the viscoelastic, and everything on table looks absolutely all right. So we are confident that things are absolutely fine. But the first post-op day, this is the picture. The whole of the temporal side near the incision, you can see the Descemet's folds, and nearly 1/3 to half of the cornea is edematous. The patient is very unhappy and the surgeon is shocked. What happened? So we do an AIOS2025 to find out that there is a wonderfully large Descemet's detachment at the incision site. But if you see the central cornea, the central cornea is still reasonably all right. It's 556. So the edema has not progressed to the center. But we wanted to find out what went wrong. So this is the laser emission that is happening. Luckily, we record all our surgeries. So we go back and find out what happened. And the rhexis is done, and this is the incision. But notice ahead of the internal incision, there's a small bubble-like thing, which we noticed on table also. And sometimes we do have these tiny little bubbles. So, and we always stain our incision. After doing the side port incisions, we injected the viscoelastic with the soft shell technique, the viscodispersive and the cohesive now. And now when opening, that bubble comes out very nicely, but yet surgeon is suspecting, and we are inserting the spatula to see if there's a large DD, but we couldn't find any. So we decided to wait for a couple of weeks. But unfortunately, after the couple of weeks, now the edema has progressed to the center. The patient is even more unhappy after 2 weeks and said, my blurring is increased. And this is the pachymetry. You can see that it's gone to more than 600, 667 the central pachymetry is. So now, again, we did the AIOS2025, and we have seen that the Descemet's has increased, the Descemet's detachment has increased. And then now we decided to do an air injection. And this is the way we use a 30 gauge cannula, just bend it. This is the way we do the air injection. And we go to the opposite side, but first the surgeon is now opening again the main incision to see if there's any fluid coming out of that incision, so that we just depress the incision a bit to see if the fluid is coming out, but nothing came out. And we go from the opposite side of the Descemet's detachment and inject air and fill the whole chamber with air so that we can reattach the detached Descemet's membrane. So with the entire air fill, the next day it's slightly better. Again, even the next day you must do an AIOS2025 scan. So it looks reasonably attached, and after 4 weeks, finally, the cornea cleared, the patient was happy. However, if you notice, there is a small linear scar at the main incision. So that is where the Descemet's was detached. And pachymetry, everything came back to normal. This is the second case of a 64-year-old female, a myope, and whom we are planning a lens-ex with a toric monofocal IOL. And irrigation aspiration is going on. We've not noticed anything abnormal. But at the end of it, we see that there is a curled up Descemet's detachment, and mostly this is from the side port incision with the instruments that this has happened. And if you notice that the Descemet's always curls up like this on itself. So you take the superior part and the surgeon is trying to smoothen it out, but it's still hanging there. We are implanting the IOL, taking care that now no instrument touches that part. And then we'll remove the viscoelastic. While removing the viscoelastic, we take care that our instrument, our aspiration port is not anywhere near that detachment. So see, you can still see that the Descemet's is curled up there and the surgeon is trying to hydro it into place. But these Descemet's membranes are so elastic that they keep curling on themselves. So this is when we decided that we will do an air injection on table because this Descemet's would not attach by itself. And we did a full air fill. And this is the next day with a very mild kind of, there are still Descemet's folds as a mild edema. But the anterior segment OCT shows a reasonably attached Descemet's membrane with a, still there was a pachymetry of more than 700. The edema was still there. But at 2 weeks post-op, this eye cleared up and you can see the toric IOL well in its place. The third case is a 72-year-old with a grade 2 and planned for a phaco with a toric monofocal lens. Again, the phaco went well, but the surgeon is struggling a bit with the IA. And the patient's eye is moving, so it's away from the field. The focus is not very clear. And at the end of the IA, we notice there's a huge detachment there, if you can see. And again, it is folded on itself. So we are trying to, again, bring it back in its place. But after the lens implantation. And notice here, when we are doing the IA, the surgeon very rightly is keeping the aspiration port well away from the site of the Descemet's detachment. We did not do any air injection because we thought that at the end of the surgery, we could reattach it with the hydro. So we didn't do an air injection, but this is post-op day 1. So any detachment that you see on table needs an air injection at that very moment. With a severe edema and a huge Descemet's detachment you can see, and the pachymetry is also more than 700. So this edema will not clear on its own. By post-op day 7, it has reduced a bit, but the detachment is still persistent and the edema has increased. So even if you leave a detached Descemet's membrane even for a couple of weeks, the corneal edema is going to go on increasing. So keeping in mind the pachymetry, the anterior segment OCT, we decided to do an air injection after 3 weeks. We did do a proper air injection and the Descemet's did attach very well. And after 2 months, this cornea cleared, but because of the delay in the large Descemet's membrane reattachment, there's a scarred cornea. So remember, this course is all about a stitch in time, air bubble in time. And of course, we cannot tell you the importance of the posterior segment OCT as well when you follow up these patients. So any interventions that you're doing secondarily, always corroborate with your posterior segment OCT. So each and every movement in the eye needs attention. All the instruments going in the eye repeatedly coat the endothelial layer with a viscodispersive viscoelastic at all stages of your surgery. And early detection and high index of suspicion, find out exactly where the detachment is, tiny detachments we always see usually at our main incision or sometimes in the side put incisions which can be left alone. But when there's a huge detachment, always air bubble it and use your imaging techniques, and the treatment options are quite effective. This is actually what we call an auto DMEC that we are doing. Thank you.
Thank you, Dr. Vandana. Those cases were really eye-openers that, and like you said, during surgery, keep your eyes open and keep your mind open to the fact that you can also complicate. Don't be blind to that. And I think prompt imaging, what I learned was that if there is anything that you did not expect, do an imaging, be it the cornea, do an OCT, if there's something inflammation, dilate, check, get the retina check, do a posterior segment OCT, vision is not appropriate, again, do a refraction or a biometry to see what's happening. So anything post-operative, you do not, it doesn't match with your expectation as a surgeon, we need to tackle it and investigate it. Any comments?
In our hands, we have always done air bubbles, not C3F8. Yeah. Yes, you can. Yes, then C3F8 would be appropriate.
That was a great presentation, ma'am. Do you want to comment on the usage of anti-glaucoma Repatec eye drop in Descemet membrane detached? Because people have been using Repatec eye drops.
Repatec eye drops is usually for the endothelial cells.
Okay.
In Descemet's detachment, I have not heard of people using Repatec.
Okay. Okay, ma'am.
It's for the viability of the endothelium,
Okay.
mostly. Early Fuchs
Okay,
dystrophy,
okay.
yeah.
Yeah.
You can take the mic.
Sir, you can use that mic.
In the podium presentation yesterday, and the suggestion from these guys I learned is to do a trapezoidal incision, because most commonly the DD occurs in the main incision. So if you do external, say 2.2, but internal a little broader, which you can do controlled way in a lens 6 or I mean flex way, but even manual, that will reduce the chance of DD occurring with the manipulation through that incision. So that was a great stuff.
I see Professor Dr. Rohit Shetty. Welcome, sir, to our course. Would you have any comment on this ripasudil in Descemet's detachment?
I think what Madam said is right. It more of helps to regenerate the cells. But the question which was asked to me is, ma'am said that there was a scar at the end of it. A lot of these challenges happen to the scar. So there are 2-3 people who have asked me whether losartan works for this scar. The interesting thing is we have no idea. Losartan works very well in the anterior 200-250 micron scar, but deeper losartan, I told that person to try it out and let me know whether it's worked, because that I think is a challenge when you have this kind of scarring. No, we make it. It's like preparation of losartan. But till you don't get losartan, the question for this scar is the lymphatic rust penetrates into aqueous humor, and lymphatic rust has maybe 30-40% of the work of TGF-beta of losartan. So losartan is commercially available. So losartan instead of using losartan, you can seek the microvision called Sika, another company called Lifnia or whatever. So I think that is a worth trying at a very early stage when you have a endothelial kind of scar she mentioned.
Thank you. So I think that's something we all could think about.
Yeah.
So
Thank you.
we move on now to our next presentation while we are waiting for Dr. Gaurav Luthra to join us. Dr. Tushya Om Prakash will be talking to us about how you deal with a posterior polar cataract which has an open capsule.
I would like to thank Dr. Vishali for giving me this opportunity. So I would be talking on successfully navigating a posterior polar cataract with an open posterior capsule. So I'll be showcasing you few posterior polar cataract cases. So this is the first case where with the posterior polar cataract with the nuclear sclerosis of grade 3. So we have been doing preoperative OCTs in all our posterior polar cataracts to diagnose any kind of these pre-existing tears preoperatively. Thanks to Dr. Pujari, he has published a very good paper on that. So what I usually do is, so this case already had a pre-existing PCR which was confirmed with the preoperative OCT with the conical morphology. So what I usually do is I keep my, there are some prerequisites involved before the surgery. So first thing, important thing is to have calibrated incisions, because you can't afford to have leakages during the surgery. So calibration of side port as well as main port is important. Active fluidics is another important thing. I don't have any financial disclosure. And then slow motion phacoemulsification approach as shown by Dr. Robert Osher and low IOP by Dr. Abhay Vasavra. So our aim here is to have an equal or minimal pressure difference between the interior and posterior segment so that there is no pushing back of the nucleus to the posterior segment. So another thing which is very important is use of oval rhexis, because this gives you an advantage of both large as well as small arm of rhexis. Large arm of rhexis helps you and there's no rise of intraocular pressure. You can do a safe end-to-end sculpting. There is easy division, easy sub-incisional cortex removal and a smooth IOL entry. With the small arm of rhexis gives you an option of optic capture, nuclear piece retention in the bag, and also helps in tamponading the vitreous. So my machine settings would be that I usually use a low IOP of 20 to 24 physiological IOP with a low vacuum and an aspiration flow rate. So in this case, the cataract was on a harder side. So for quadrant, I usually increase the vacuum, and as Dr. Vasavra says, you can also keep the aspiration flow rate low. So starting with the case, the first important thing is have calibrated incisions, so to have minimal leakage, good chamber stability, and oval rhexis, as I already told you about the advantages, it gives you an advantage of both small and large arm of rhexis, and you can also, it gives you an option of doing an optic capture later on. So my aim here is to do stop and chop technique, slow sculpting, slow division of the nucleus, and slow motion phacoemulsification, because you can see here I'm slowly dividing the nucleus hemispheres. Cross chopping is done where the nuclear piece adjacent to the 6 o'clock is being aspirated as shown by Dr. Ron Yaw. And now the remaining hemisphere is slowly divided so that it is separated from the other hemisphere. With the back flip, it is brought into the interior chamber, and you can see my IOP settings. They are all low phaco parameters, low IOP, low aspiration flow rate. The aim here is to have a minimal pressure difference between the interior and the posterior segment so that these nuclear pieces are not pushed back. There is no undue deepening of interior chamber, no posterior bulging of the posterior open capsular defect. The remaining hemisphere is brought into the interior chamber, and it is slowly aspirated. I would like you to focus on those three nuclear small pieces which are lying over the hyaloid phase. So minimal turbulence and low pressure fluidics prevents any disruption of the hyaloid phase. So what I'm trying to do here is I'm trying to use the hyaloid phase to my advantage. So that is acting as a shield to these small nuclear fragments. You can see those two small nuclear fragments which are just lying over the hyaloid phase, and it is acting as a shield to these nuclear fragments from going back. So low IOP phacoemulsification maintaining the equilibrium, the interior chamber pressure and the posterior chamber pressure. So there is no disruption of the, always remember to inject viscoelastic before taking out the probe to maintain the chamber sending. Remember not to overinflate the chamber with viscoelastic. And with visco expression, you can see that one of the nuclear, small nuclear piece is being taken out. Remember not to overinflate it, have to be done meticulously. Dry aspiration by Gill's technique has been followed to prevent any vitreous hydration. And you can see here that with the dry aspiration, the remaining cortical matter is taken out. And with now, my plan here is to inject an IOL into the sulcus, as I already had an oval rhexis, so I'm going to use that to my advantage. I'm going to do an optic capture, and you can see here this remaining small nuclear fragment which was lying over the hyaloid membrane, and now the lens is optic captured, and triamcinolone acetate confirmed absence of vitreous, and the case was completed. So with this animation, I would like to tell you is that when you have low chamber settings and low IOP, these nuclear pieces, they just bounce back, and hyaloid phase acts as a shield to it. So this is another case of posterior polar cataract where with a young 32-year-old male, overly soft posterior polar cataract, preoperative OCT shows moth-eaten morphology, which confirms a pre-existing defect. So now I'm gonna start my case. Calibrated incisions is very important at the start of the case, and then followed by an oval rhexis. So this has both the advantages of small and large arm of rhexis. So I can use this to my advantage later on by doing an optic capture if needed. And now as ma'am had also shown initially, that these overly soft cataracts, so we don't do hydrodissections in any of these posterior polar cataracts with pre-existing defects. So I'm gonna do layer by layer hydrodelineation. So where the BSS is injected at different levels and different planes. So aim here is to have these layers, because to have a good thick epinuclear sheet, the outer nuclear layer is used as a scaffold, is used as a shield to the open posterior capsular defect, and the inner nuclear layers are phacoaspirated. They are phacoaspirated slowly, keeping in mind not to do any rotation maneuvers. So the inner nuclear layers are aspirated. The chopper helps in doing a mechanical delineation of the nuclear layers. So with the mechanical separation of these nuclear layers and phacoaspiration, the inner nuclear layers are taken out. So what I'm going to do here is, as Bob Usher has also mentioned, I'm trying to take out the epinucleus on the opposite side. So this gives you an escape route to the BSS, which just goes and immobilizes the outer nuclear layer without providing any stress on the posterior capsule. So with the escape route, and always remember to inject viscoelastic before taking out the probe. So bimanual IA could have been done. So what I do is I do a high sleeve retraction of coaxial IA, so that it gives you a different level of irrigation and aspiration, which simulates a bimanual IA. So now the epinucleus is taken out from all the ends. So once it is taken out from all the ends, and it is aspirated softly, and always remember to use low phaco parameters, low IOP, because you don't want your posterior capsular defect to extend. And once it is dislodged from all the ends, it is aspirated quickly. So you can see here, there's always remember to inject viscoelastic, not to overinflate it. So you can see the posterior capsular defect. I'm trying to regularize the posterior capsular rhexis. So I usually go in through the side port just to maintain a good chamber stability rather than going from the main port. So now it is rounded off. And from the other side also, I was trying to round off the rhexis. So to have a, so now triamcinolone acetate confirmed the absence of vitreous, and the IOL is injected into the sulcus with an optic capture, and the case was completed. So this last case, a very short video, just wanted to tell you about this case. The patient was diagnosed with a preoperative PPC with pre-existing defect, confirmed by OCT. So, and patient was a high demanding patient with high amount of astigmatism, wanted a toric IOL. So as a routine case, I continued the phacoemulsification, low phaco parameters. The nuclear emulsification was completed. You can see a typical posterior capsular defect. Remember to inject viscoelastic before taking out the probe, and IA was done. And now again, always remember to inject viscoelastic before taking out. So what I'm going to do is I'm going to regularize my rhexis by trying to rounding it off. So once this is done, what I'll do here is now I'm gonna inject a toric IOL. So I'm gonna do it in such a way that I would place it over the iris. Make sure that your chamber is adequately deepened with the viscoelastic. Align it at the axis. So once your chamber is adequately deepened, you slowly flex your haptic into the capsular fornix. So it has been lined before by keeping it on the iris, and with the other haptic going in, you can just place it in the back. So this is one way, and other way is what Dr. Vasavra says, to do a reverse optic capture also. That also you can do. So thank you so much. Yes, ma'am. Yeah, so I've tried it in few. That's why I go it through the side port. Make sure that like it is at the chamber is not overly inflated adequately. Yeah, yeah. At times it is through and through, so you can't do it in that. Like, but if you have a smaller one, you can try.
I think, like you rightly said, ma'am, a lot of these are very fragile, floppy kind of
Yeah.
capsules. So you can't always convert it, but those were very good tips, Tushar. I think the most important thing, like you said, is pre-operatively anticipating and also counseling the patient that things may not go as you were planning. So if you have a retinal surgeon available in your hospital, it is a good idea to have them on call that if I need, please come up and scrub with me. If not, you need to tell the patient in both situations that we might have to go behind and do a vitrectomy, and which is because you have this defect. And these imaging I also find very important because you can show the patient pre-operatively that this is what you have as compared to what a standard cataract would look like. So in these days it's also very important to have these attached to your case reports so that you have a record of what you were doing. And I think the other surgical points were very well taken. Lower your parameters, slow down your technique, always inject dispersive viscoelastic before you withdraw, and having a good rexis size so that in case you have to do a sulcus implantation with or without capture, you shouldn't have too large a rexis in these cases. Any other tips, Rohan or Dr. Vanna?
So, emulsification in the bag versus emulsification in the AC. Like in softer cataracts, it's fine to do that. But like when it comes to slightly harder cataracts, how do you decide that? Like in posterior polar cataracts.
In posterior polar cataracts, I try to do, first of all, we don't have to rotate. So if it is a harder cataract, try to do cross chop, okay, or as I showed you one.
No, emulsification, the quadrant removal.
So in quadrant removal, I always take it in the safe zone. I always try to do it supracapsularly if there is a pre-existing defect.
So I think, Rohan, that's also a good point, but like many stalwarts have taught us, if you reduce your parameters and if you're slow, most of the times you can manage. In bringing it supracapsular, sometimes you may be, if you don't know there's a vitreous, you might be pulling more vitreous. Second, you are working close to the endothelium, so even the fluidics and everything, you don't want to add a component of corneal endothelium. So as long as you can, maybe last fragment, yes, but as long as you can, I would suggest just go slow with your bottle height, flow rate, and adequate vacuum, and most of it will be done in the bag, or at least at the iris plane.
Yeah, iris plane.
Yes, sir.
Yeah.
Yes, sir.
Yes, sir, yes.
Everything needs more and more proof of why it is happening. See, posterior polar, if I'm right, it's a remnant of the hyaloid system which is altered. So I think you said some of them behave differently, some of them. So it is very important to study the proteomics of those caps, because you took it out very well, and preserve it, and say around 20-25 of these capsules, if you're able to provide along with the lens, and compare it with the non-polar ones, you might unlock a completely new pathways. See, the question is, what happens if you unlock a new pathway? There is a potential tomorrow for a drug delivery of system, something. I mean, we never know what you will unlock it. So my suggestion is that, because when you are taking out those rexes of the posterior, it is a phenomenal use to science. And there are people who have worked on anterior capsules, different types of anti-capsule, the capsule which has fibrotic. And there's a work done here which shows that the fibrotic capsules can be prevented by using something like resveratrol, because this has a tremendous role in reducing the fibrosis. We never know what you get. Just a suggestion from a non-cataract surgeon is that now you all mature to a level of phenomenal surgical skills. Now I think you should put your efforts into unlocking the pathways of these rare types of cataracts, and how you can look at what proteomics are involved in it. And if you visit one of your labs, and whether in Ahmedabad or Amritsar, I think they'll be able to do it. It's not so complicated.
I think that's a great suggestion, and a few years back we have done some studies on the plaque capsules, but I think we really haven't done a head-to-head on normal versus polar, so yeah, it's time to work together.
Great comments, and thank you for suggesting these paths. We attempted a few paths like that, but we are still lost. But I just want to congratulate you, Tushar. Wonderful, wonderful skill and exhibition. I just want to emphasize one point. There are many points, but if I have to single out, in addition to what you said, is the delineation, and you showed it very well. Creating a cushion, protecting the weak, fragile capsule during the removal of the nucleus is very important. And there are many ways of doing it, but you need to do delineation. Doing it in a conventional way, sometimes the fluid goes inadvertently into the wrong subcapsular plane, and then it can hydrorupture it.
Yes,
So I think doing a technique called inside-out delineation or something, create a space in the middle and then delineate to avoid
Perfect.
that inadvertent thing would be a good idea. You can do much controlled way in the
Yes,
flex
yes.
technique, but that kind of creating a cushion is very useful, particularly if there is already open capsules. But you showed it so well.
Thank you, sir. Thank you.
Just one question, Dr. Om Prakash. You showed the dry aspiration of the cortex. What
Yes.
is the cannula through which it was coming out so easily? And what was the viscoelastic at that time?
So, ma'am, I was using a viscodispersive HPMC, and it is a 25 gauge cannula. This technique has been shown by Dr. Gill. So it is, you can always, ma'am, read about it. So it is irrigation, aspiration, fixing, teasing, and stripping of the cortex with the.
Thank you.
So we move on to the next talk, where I'll be. Can I have the slides on the screen? And before that, a warm welcome and good morning to Dr. Gaurav Luthra. Thank you for joining us. What to do when the vitreous mixes with the aqueous, sort of a continuation of what Dr. Om Prakash showed us. What I feel are good tips for an anterior vitrectomy. So here I want to start with this case just to see that everything looks okay. The surgeon has started chopping and I'm watching. I'm just half looking at my WhatsApp and supervising or looking at what is going on in the OT. And everything looks okay. So, but I want you to focus here. I keep seeing this nice red glow here, but the surgeon is completely blissfully unaware, and it's rotating well, it's chopping well. Everything is going okay. This was not a polar cataract. Now next step, the fourth chop was created. Until now you saw that 3 chops were created and the nucleus was rotating very well. But now suddenly the nucleus is not moving that well. But that's okay, the surgeon thinks that I already have 3 good quadrants, and the surgeon removes this piece and it's being eaten up everything looks perfectly okay, the parameters, and there's nothing really wrong. So this was just to show that everything here is going fine. Now this is the last quadrant. Again, just to show that the nuclear fragment removal has gone on uneventfully and things look okay. The surgeon is very confident that it's all well. But you will now here see something that the surgeon did not notice in the hurry of. Sometimes what happens when you take off the instruments, you tend to take off your eyes off the microscope. So one thing that I don't know how many of you have noticed this here, the surgeon still hasn't noticed. That's okay, that can happen to all of us. And now an IA is being performed. But the good part here throughout the surgery, because generally we like to use modest parameters, is that the IOP is always maintained at about 30. The vacuum is not more than 300, 400 in an average nuclear sclerosis. But it is at this time that the surgeon now feels that there is something here in this zone while doing bimanual IA. The other good thing I also like about performing a bimanual IA in routine scenarios is that one, you can maintain a closed chamber, and second, if you do have an event of a PCR where you should perform a bimanual anterior vitrectomy, you are well versed with how to perform, plus you have those 2 ports already ready with you. So at this point, it is now that the surgeon really feels that in this area there is a clearing and realizes that there is a PCR. So now starts this whole story of what to do. I think the first tip, we should all keep calm. Do not pull out any instruments in your panic and think and assess. So stop there with your instruments in the hand. Your hands stop, but your mind starts working. And assess the extent of the PCR and vitreous is there or not, and so then you know how to deal with it. Now, how do you identify vitreous prolapse? We'll go to next step, which is I think the most important step. See at what is the extent of the rupture, whether there is vitreous, and start thinking about a backup strategy. So I always ask my OT assistant at this time that please check if we confirm and get it in the OR the appropriate 3-piece foldable IOL backup power. And identifying vitreous, I think we all know this by now. Preservative-free intracameral triamcinolone acetonide, which is available with multiple brands to our advantage in India here. So this is what the surgeon now does. Before removing the irrigation, the aspiration is removed. Through the same side port, triamcinolone acetonide was injected, and as you can see, it's a freely swirling, so there is no vitreous at this point of time. Now this is the step number 1 before you proceed to vitrectomy or no vitrectomy. So I think this junction is very crucial to identify vitreous. Then second, as we said, don't panic and don't pull out instruments. Inject a dispersive viscoelastic chondroitin sulfate here with no financial interest, because that tampon not only maintains the chamber, but it tamponades the vitreous and prevents any vitreous from coming forward. This is another scenario from a different case, just to show that whatever stage you recognize a PCR, as you can see here, please inject dispersive viscoelastic before you come out with your instruments. Don't jerk out the instrument. The second most important, or probably the first most -1 step of any surgery should be, before you start, you should have an entire, you can have either a separate box which has all the PCR instruments, or a PCR kit or something like that, where you have necessary microforceps, trocar, rings, viscoelastic, triamcinolone, pilocarpine or myocol, and the vitrector, of course. So this again is a different scenario, not the one I started off with, and I'm showing this because it has the slit attachment which will help us to understand that assess the PCR. Once you have injected viscoat or dispersive viscoelastic, use your optimal ergonomics to see how the PCR is, and then see using triamcinolone. Now sometimes in the presence of viscoelastic, triamcinolone gets jumbled up, but a strand always comes out as a separate thing. The other thing will appear as a blob, the viscoelastic. The first principle is to manage vitreous. Anything that you identify, you have to address before you move on. So before you put in a scaffold, or before you put in any retrieval device or do a hydrovisco expression, I would recommend that we perform anterior vitrectomy at whatever stage we are. This should always be bimanual. And use paracentesis. Don't use the main incision, because that is leaky and you will end up pulling more vitreous outside that temporal or superior, whatever incision you are making. Now, the goal of an anterior vitrectomy at that point, if you are not also a trained retinal surgeon like I am not, is to prevent further enlargement of PCR, remove the vitreous properly in the area where you want, and make sure that you have a good symmetric support for the IOL, and so that you end up with a centered IOL wherever you place it. So then the golden question is whether you would like to do both limbal or whether you would like to go pars plana. I just want to show these two animations. Now when I say pars plana, I am not talking of a 3-port vitrectomy. I am talking of a topical cataract surgeon performed anterior vitrectomy where you put your irrigation through the limbus and your vitrector through the pars plana and you drain out the vitreous. Now this animation Samresh has shown many years back and you might have seen it, but it's still very important to show that when you are performing limbal vitrectomy, you're actually dragging more vitreous upwards and you will cause an enlargement of your original PCR. Versus if you're going through the pars plana, you are sucking the vitreous into its native compartment, and therefore as you can see here, you will end up having almost the same size of the PCR. And this again is a slow motion high speed video to show that when you perform a limbal anterior vitrectomy, you can see the turbulence that is happening because of the drag to the vitreous and the PCR is actually enlarging. Now even when you turn the port downwards through the under the PCR, this turbulence is still pretty much the same. So my point is that limbal vitrectomy does lead to enlargement of the PCR. On the other hand, if you have your irrigation through your corneal side port and pars plana vitrector with the same phaco machine, you see how stable and tranquil the margin is and there is no turbulence. You won't end up enlarging the PCR. So like Tushya showed, you could potentially convert it to a rhexis and then do an in the bag. Again, we did some Miyake Apple View studies to show that limbal vitrectomy, you really don't have good access. You can only access a little bit, not very uniformly. Whereas if you go pars plana, you can see that you have a symmetric removal 360 degree. So this also creates a uniform platform for a stable IOL fixation. Now this is how you would do it. This is triamcinolone. I want to again show this clip from a different case to show that when you perform a pars plana vitrectomy, just notice in this area how this strained vitreous will get pulled back without any turbulence in the anterior chamber. So this is vitrectomy as a routine in all PCRs now. Helped us change our practice to a pars plana vitrectomy as a routine in all PCRs now. Now moving on to the original case where IA was completed, now that there was no vitreous, dispersive viscoelastic is placed. But look here, one little fragment has gone into the anterior vitreous. So we complete bimanual IA, we remove the cortex, and now again before removing that, inject dispersive viscoelastic. Now the next step, you can see here, I just wanted to highlight that there is a little fragment, there is no vitreous, but you don't want to leave this and think that oral steroids will do the job. So we use a trocar, and because we have retinal colleagues, we can borrow these from them, and any of your friends could give it to you. At 3.5 millimeters behind the limbus, this is all being done under topical anesthesia. A trocar is being put, and you will notice that it's not always very easy. There will be some pressure, but it's doable under topical with some support from your NS. And you put in a trocar. Now we can see this fragment. What parameters do you use? Maximum possible cut rate on your cataract vitrectomy machine, moderate vacuum, and a very modest bottle height or an IOP. You use the cut IA mode, that means cut and aspirate, not aspirate and cut. You need to understand this also. So in the same case, now what is happening is, the vitrector was introduced through this, the irrigation is still limbal, and that fragment was removed. As you can see, it's gone off very smoothly. We don't need to do a complete vitrectomy, we are just doing a limited and symmetric anterior vitrectomy here. And in the interest of time, I'll just forward this. Now this patient was planned, as you can see here, I'm not branding any company, but I'm just trying to say that he was planned for a trifocal toric IOL. So you can see here that because the PCR, if you can notice it here, is limited in its extent, there is no vitreous. I'm gently going and implanting this trifocal toric IOL inside the capsular bag. Now here two things. If you are using a very, very tight incision, I would recommend slightly opening it up so there is no jerk or force on implantation. And the kind of material, something that opens up very slowly and allows you to manipulate before it completely opens up, makes a big difference when you are implanting. And we are gently bimanual rotation, like I think Tushar brought out with hydro. We are doing the same 2 Lester hooks to rotate the IOL into its desired axis with the image guided system. And you can see here that the desired axis actually is at the edge of the PCR, but still the IOL is very well in position. Now we are removing the OVD from top, and you see that my irrigation or my IOP has dropped to 20 millimeters. My flow rate is very low, only 20 cc per minute, and I'm using only adequate vacuum of about 250, 300. I know that I will be left behind with some viscoelastic, so I will tackle it with giving a Dimox or a Timolol after surgery. And now again, before I remove this, I hydrate my ports. And not only that, you can see here end picture, very well stable IOL, and what I wanted to again highlight is these 2 sutures. Even if it's a 2.2 or a 2.4 incision, I will take interrupted sutures. And this is 1 week following surgery. This is what the patient looks like. This is the actual refraction, 6.6 partial N6, and this is the eye trace showing a perfect refraction and the OCT. So I think the other point, last point I want to make is record all your cases so that if you have a complication, you can go back and understand why and where it happened. Thank you so much. And I think we move on to our last but not the least talk of our course, Dr. Gaurav Luthra, and then we'll pause for discussion. Welcome, sir.
A very good morning. There is too much, and most of these you can see that this pupil will not require a device because we'll probably be in and out before the pupil comes down further. So another situation here, you can see a small PI there. Now here we are doing a small stretch to see if we can get a pupil which is enough. Again, these are few old videos that I pulled out to see what we can do in such situations. Again, then doing a viscomydriasis here, trying to make room for the rhexis and using a globe stabilizer. Now it's at this time sometimes the pupil comes down when the moment you do a hydrodissection, that's when suddenly the nucleus gets mobilized and your chamber depth changes and you can get into this kind of a situation. Now here I wanted to showcase that once your lens is out, pupil has obviously come down a bit and you've been able to do that. And I'm trying to do cortex extraction. Now this is a irrigating chopper, irrigating infusion cannula. So sometimes when I'm doing torics and I need to visualize, or if I'm doing a polish, so this becomes like a third hand. You can just use this as a third device. And somehow my close friend Kumar and me designed this at the same time. The only difference is that I made the Y vertical and he made the Y horizontal, and then we fought about it that who made it first, because I could show him a video of this like 1 year before he started showing it. So anyway, but this is a very useful device. You have this small Y thing at the tip, and it can just be used as a third hand to go around and move the pupil away. And also when checking your toric marks and everything, it becomes very easy, so you don't need a third device. So going on, now this situation is obviously a pseudo exfoliation, and I'm trying to do in this situation without using a device, and again using viscoat, which helps you keep the thing in place. Now I know that some people don't like to do this stretch, but I've realized that if I do a little bit of the stretch, I get enough room that I don't need to put a device, because if I put a device, it will still do a stretch anyway. And most of these times I can complete my surgery without needing a device, and I only use a dilating device when I have to. So if you follow the principles, good viscoat in the tear chamber, not only to protect the cornea, but also I like to see that while some people might want to use a heavy viscoelastic, I think that viscoat does a great job of also tamponading and keeping the pupil out of the way of the phacoprobe, and also doesn't let it flutter as much. So you can see that the other thing I'm doing here, if you look at the top right, we are using an IOP of 25 millimeters of mercury. which is very good because in this situation, as Vishali was also showing, at a very low IOP, the fluctuations in the chamber are the least. So the iris tends to misbehave the least as well. When you have a lot of high settings and high fluidics and high flow rates and vacuum, you'll tend to get the iris into the phacoprobe repeatedly. And also there's turbulence in the chamber, and you can see that you don't really need high IOPs and high settings. I'm also using very little phacopower, and I'm mostly using the forces of separation and cracking without even embedding too much. You just need to have the mechanics right, and you can get everything out, and the pupil does not come down on you. This patient was also on Urimax, and so I was expecting this patient to have possibility of floppy iris syndrome as well. So you can go through your surgery quite easily, and with little turbulence, and you can complete almost all of it without needing any device. So going on. Now here, this is again, I pulled out an old video to show what else can be done. I rarely do this maneuver anymore. I'm of course separating the synechias, but after this, during the surgery, if I remember correctly, we stained under the pupil with the air bubble there. I do a stretch. Now I'm getting sphincteric tears. Now I don't like to do this anymore. If you really want to do something like this, if there's a very tight sphincter, you can do a small sphincterotomy. Again, a very, very old scissors, Vanas kind of a thing which I'm using. I don't think I've used a Vanas now for some time, because you have very elegant micro scissors available. But basically to give you an idea that this is how you can deal with those sphincteric, very tight rings on the sphincter, because you'll eventually not be able to do much about it. Even with a Malugins ring or with hooks, you'll end up tearing the pupil anyway. So you can then get a space to work like this. Now going on, I think here we have again a small pupil, and I'm using phenocaine. So this has become a very useful device. Phenocaine is basically tropicamide and phenylephrine. You can see that some patients, who are not dilating preoperatively with in the waiting room with ketorolac, phenylephrine and everything, will not. So here, of course, I think this patient we had taken up for a femto. So we put phenocaine, got a pupil to dilate a bit, took him to the catalyst OT, and then managed to get enough room to create a rhexis. The good thing is that if you're using a device like a BHEX or a Malugins, your incision is much bigger. But if you're making only a 1 mm side port and putting phenocaine in, you can just have a good seal, and the incision doesn't leak when you take them for a femto-assisted surgery, and you can complete the surgery without any problems there. So I just thought these few cases. Now this is a very unique situation. I had a very high hyperope who was in the 40s and wanted a refractive lens exchange because there was nothing else that was possible. We plan to do a femto-assisted surgery, and if you notice here, we are using a 37 diopters IOL. The AC depth was small but not too bad, and both eyes were planned. And when we went in for the first eye, amongst my 4 or 5 femto cases, you can see that the pupil is nice and big and well dilated. So I never suspected that I'll run into trouble. But when I went to the OT, this was the 4th case. So by the time I reached, in the Lensex, I used to get, meiosis quite regularly. On the catalyst, we don't. Even if I'm doing 7, 8 femtos, after an hour, if I see the patient, I will not see it. In this patient, you can see the capsular thing is actually lying over the iris. It's become so small that the capsule is lifted off. I didn't realize why it is there. I tried to use phenocaine. I did everything that I could. Nothing would work. So I was working through a 2 mm pupil. I tried viscomydriasis. But frankly, I was lucky that there were no adhesions and no attachments of the capsule, and because it was a very soft cataract, I could get away. So while this surgery eventually went off well and I managed to get in, now the problem was that how to plan the second eye. So here I'm injecting the lens and checking to see that everything is good. Now when we decided to go in for the second eye, I had to do something different because I was expecting it to behave the same way. So here, of course, a thick lens going in, and we managed to get a good result. For the second patient, for the second eye, what we decided was we'll do a femto anyway. We also used preoperatively, a couple of other things. I was putting ketorolac for 2 days, and I, tried to use multiple mydriatics to see whether, we can put hometropine and cyclopentolate to see if it, stays. What we essentially did was that we kept it as the last femto patient and took him in for the first, surgery. So the pupil still came down, but you can see that, I was able to. So I've never been able to understand why this happened in this particular case. And then it was refractory to anything. So after I finish, I'm going to ask Vasavada sir to see if he's ever encountered this in a very high hyperope and why this would happen. And so here, of course, you can see that surgery is much, much more straightforward. Now this is again a very old clip, as you can see from the video, and this is probably where I'll end the surgery today. Now this was a very high myope and a patient who was on Urimax, and this is the time when this was floppy iris syndrome had just been described. You can see that the pupil is very, very bad, and as I'm trying to embed, it just comes out, and I'm thinking, what should I do now? I'm preparing, and I tell my assistant that, pull out the ring or whatever, the hooks at that time, whatever was available, and I'm kind of waiting. And then I think that while he's doing that, let me go back and see what, whether I can still proceed. Just see what happens. You have a full pupil. Basically, it's because of the block syndrome where the, iris kind of bulges forward, and so the fluid accumulates behind it, and all you have to do is move the iris aside or the pupil aside, and the fluid trap comes out. Sometimes it doesn't come out. If it doesn't come out in spite of whatever you do, just see what's happening again. I'm kind of trying to get those chunks out before the pupil comes down. You can see that the iris is billowing, and as I'm having these, you can see that movement. Now there's fluid trapped behind it. The pupil has come down. So even while my staff was trying to bring that device out, I just did the same thing. I came out, released the pressure of the fluid which was trapped behind, and you again have a full-size pupil. And this actually has happened to me a couple of times now, and I sometimes get away without using any device. So sometimes you can move the iris aside by a chopper or something and get the fluid to come out. Sometimes it doesn't happen. Then you have to just come out, let the fluid escape from the chamber, let the chamber shallow, and then see again. I was able to bring out one chunk at a time, and the pupil would come down. It's a very blurry video, but it kind of gives you the message that this is how we can do it. So with that, I'll stop, and I hope I was able to give some small pearls. So thank you so much.
Side port, through the side port, I just tent up the iris. That itself.
I know.
releases it.
We
That's
usually
all.
do that. In this patient, I tried that a couple of times.
And you
Sometimes,
showed
yeah,
them
but
the way
it
of
wouldn't
doing
work. And then, I just had to come out, let all of it escape. And then, so basically the same thing, but, just work like that
Yeah,
better. And
but
I did
other
it like
thing-
5-6 times, and I could complete the case.
The other thing, I see that, of course, I think there are also older videos. You do like to stretch your pupil a lot.
I've stopped doing it
Then-
much now, but yeah,
these
at one time.
floppy iris cases will get
Worse.
worsened.
They get worse,
So
absolutely.
how would you,
So nowadays
how
I
would
use.
you differentiate one woman is 60 years old or a guy is 60? Is it a senile pupil or is it a floppy pupil? Right in the beginning itself, you have to plan your action.
Right.
So how do you decide?
So I typically would, when I'm starting a surgery, I would assess how big is the pupil. Will I be able to complete this? And of course, there's a proper history taken. If somebody is on, sometimes even the ladies are on, the same drug, tamsulosin kind of a drug as well. So we take very meticulous history about it. And then, I would typically not even do a stretch anymore. I would use Viscoat and Phenocaine to see if I get a pupil. And especially now, because you can mostly finish your surgeries in 2-3 minutes or 4 minutes, the pupil doesn't really come down as fast as, in the past, I would take 20 minutes to finish the surgery. And, so you don't have much, this thing. But of course, if there's a situation where I'm expecting that the pupil is already to begin with 3 mm, just 3 mm or something, I will move to a device. In fact, I just skipped the 3 videos of how to use the Malugins ring, the BHEX and the iris hooks because everybody's used them. But I've seen that my usage of devices has gone down drastically. And also it helps to put some of these patients preoperatively on atropine in addition to ketorolac drops.
Ketorolac.
Yeah, so ketorolac really works well for 2 things.
Yeah.
One is for maintaining intraoperative, mydriasis, and second also for topical phacos, the sensation of pain for patients is almost negligible if they've been on 48 hours of ketorolac 4 times a day, 3 times a day. So
Nice presentation.
Thank you, sir. Those were really a myriad of cases, and every case showing a different pearl. So I think the whole message we all got is be prepared and be open to using different strategies. Don't have a fixed way of, I only do this, I will never use a device. Use different strategies for different cases depending on what you see at that point. And like sir showed very beautifully, when you have a problem in one eye, or if somebody else has done the first eye and you see iris chafing or signs of previous iris trauma, you be ready to have that yourself, because it's not like that was a bad surgeon. Maybe the eye has that predisposition.
Especially for our flax patients, we always start Nepafenac 24 hours before the surgery. Because what we've classically seen that it is well dilated at the time of the femto, but moment patient comes inside, the pupil has come down. So then we need to use intracameral adrenaline and all. And the pre-operative examination should not happen the day before you're taking the surgery, because there's iris fatigue. The next day the pupil doesn't dilate again. So we usually have at least 2 days in between the pre-operative and the final surgery date.
Also on the same lines, sometimes the patients come in the morning, they've been dilated in the morning, and you have a long list. So the staff tends to dilate all of them at the same time. And by the time your patient comes in about 4 or 5 hours later, the pupil has already had fatigue, and they'll start constricting, and you'll have a trouble. So even that makes a difference. Also here I wanted to point out that phenocaine, while I did show that we can use that, or one of those similar things, in our setup we realized that when we were doing trials for phenocaine, while it works beautifully well and I still use it, if you use it, in a lot of cases, you'll sometimes see increased incidence of CME. So it has to be used only when it must be used. It should not be used as a routine. And this is not published, and this is just, kind of things without any actual proof. We don't get CME much now at all. But during this time, when we had probably used it over 100 eyes, to see that if we could get away by, just using this as the primary way of dilating the pupil without putting preoperative drops and everything. So we realized that we had 2-3 instances of CME which couldn't be explained by anything. So we stopped using it like that. We now use it for only as a reserve drug when it's required.
I think that's a great point. Anything intracamerally that you use, the lesser you can, the better it is. I remember we used to put adrenaline and gentamicin in our BSS. So
No, those cases could have been some OCTs which were not done for those cases. We actually have started using phenocaine as the intracameral first step for all our patients. All of us have started using. We have not seen any CMEs, and now it's for a number of years, and our numbers are huge also. So it could be that also, because it's such a lovely drug, if we actually
thank you. So I think we are at the end of our allotted time, and I really thank all the speakers wholeheartedly for making such wonderful presentations, and the audience here for being here, including all our seniors throughout the course in this early morning. And I wish you a good meeting, and we hope to see you at the APA-CRS annual meeting in Ahmedabad in August 21 to 23. So thank you once again for being here. Thank you.